Welcome, and thank you for tuning in to Derm Docs, powered by LiveDerm. This episode marks the kickoff of a two-part educational series to raise awareness of Epidermolysis Bullosa, EB, and the latest FDA-approved treatment options for this disease. Our host, Dr. Joyce Teng, Professor of Dermatology and Pediatrics at Stanford University School of Medicine in Stanford, California, is joined today by Dr. Michael Lavery, a pediatric dermatologist and clinical assistant professor at the University of Florida in Gainesville, Florida, as they discuss the clinical presentation and disease burden experienced by patients with EB.
Welcome, listeners, to part one of this exciting educational activity on epidermolysis bullosa. I am Dr. Joyce Teng, Professor of Dermatology and Pediatrics at Stanford University School of Medicine. I'm joined today by my wonderful colleague, Dr. Michael Lavery, who will join me in discussing the epidemiology and patient impact of EB, as well as some persistent gaps in the care and overall disease management. Dr. Lavery, it's a pleasure to be here with you to help raise awareness of EB for our clinician audience. Can you please start by introducing yourself to our listeners?
Thank you. I'm Michael Lavery. I am a clinical assistant professor at the University of Florida. I have a specialist interest in EB, as well as chronic itch. And so it is a pleasure to be here.
Well, thank you. So, Dr. Lavery, let's kick things off by answering a few questions in regard to EB, what EB actually is, and what it affects for our listeners that who may not be as familiar as you are. Go ahead.
So, epidermolysis bullosa, or EB, is a group of heterogeneous inherited skin fragility disorders. There are four major types: EB simplex, junctional EB, dystrophic EB, and Kindler syndrome. And specific genetic mutations have been identified in each of these, and there are around 16 separate identifiable genes to date. EB simplex is the most common subtype, roughly accounting for about 70%. Then dystrophic EB, junctional EB, and Kindler is very rare, with around 400 reported cases. The prevalence and incidence is very different in different countries. In the US, it affects about 1 in 20,000 births. So there are about 200 children a year born with EB in general. And the prevalence is about 11 per million population. But in different parts of the world, that can be different. So in the United Kingdom, the prevalence ranges from 15 to 35 cases per million. In France, it's about 12.7. In Australia and New Zealand, it's about 10 cases per million. And then in the Netherlands, they produced a large epidemiologic study of over 450 patients in a 20-year period, and they have about a prevalence of 22.4 per million.
Yeah, I totally agree. There's a lot of variations. Sometimes it also depending on how severe these patients are, and some patients with milder symptoms that they may or may not be registered, and so it may or may not contributing to the statistics that we've learned. So I have the same impression that it could be a little more prevalent than what we know. So what are some of the common clinical symptoms these EB patients have?
So the symptoms are very wide-ranging. Often patients are born with the classic symptoms of EB being blisters. Sometimes the blisters aren't always present, and they're the denuded or eroded areas of skin. And that can be anywhere in the body, trunk, face, hands, and feet. And not only can you see these blisters on the skin, but they can be inside the mouth, And especially when the babies are born, you have to go look for that because it's not always evident. And then patients can also have involvement of the genital and perianal area. And then as well as the skin, EB can affect mucosal sites. So anywhere from the larynx, pharynx, GI tract, right the whole way down to the perianal area can all be affected. So that's kind of usually how they present around birth. Sometimes the nails can be affected, sometimes with lack of nails or dystrophic nails. The blisters can sometimes occur around the nail site itself. Patients can have fusion of the digits called syndactyly or other digit problems. So the symptoms can present, or the clinical features can present very wide-ranging. And then as the children get older, they will start to highlight other symptoms such as itch, which is really a big problem. And I see that a lot of my patients. Pain is another big problem as well. And then they might also have issues with feeding or eating certain types of food, having GI symptoms, etc. And then finally, this can have a huge impact on their mental state. And so they may complain of symptoms like that as well.
Yeah, this is indeed a really complex multi-system disease for these patients, and it's a lifetime challenging disorder. And sometimes it's, especially when the blisters, contractures, and scarring happen in those particular area. For example, the eyes, including right, and they also blister very easily and impair patients' vision with the chronic disease and the chronic disease manifestations, and it can really impact other organ systems. And you touched upon a lot of it different area, and maybe also. Do you have some examples that you can share with the listeners about just longitudinally, chronically, and these patients' journey, how it impact them?
Yeah. So you made a point about the eye symptoms, and sometimes at birth, it's not very noticeable or visible to us as dermatologists that there is an eye problem. But I've had a number of patients who were in NICU who the eyes look fine, but when pediatric ophthalmology see the patient, they make a different assessment. And so I think it is important to get these multidisciplinary team members involved from the get-go, because this can have an important impact on their management. So I agree, pediatric ophthalmology, pediatric ENT, maybe having a dietitian or the peds GI team, and then, of course, other members of the EB multidisciplinary team management. With regards to the longitudinal care, I have a particular interest in itch, and a lot of these patients struggle with itch. The itch can be multifactorial. It can be brought on by changes in temperature, humidity, sweating, dressing changes, stress, infection, and then, of course, some of the treatments that we give, such as opioids for pain, will also then in turn cause itch. And this can be really challenging, but also very debilitating for the patient. Pain is a big problem, either at sites of the blister, the erosion, if they have syndactyly or contractures of the hand, that can be a big problem. And then, of course, if there's any intraoral problem and they have difficulty swallowing, even if it's liquid, this is often a big component of what patients complain about.
Yeah, indeed. I have had a similar experience. That's why in many of these EB centers across the country, we have many specialists involved in the care of these patients, and we're going to talk about it in a little more details. And you have mentioned about many of these day-to-day clinical challenges these patients have had. For blisters, for instance, changing dressing could be really, really difficult for many of these patients. And, that's always for my patient population, and they have to really mentally prepare themselves for these daily events, and takes hours. So maybe we can go back to the beginning a little bit and talk about some of the aside from the clinical challenges, and maybe other issues patients may be struggling with as well. For instance, to get accurate, early, and accurate diagnosis for EB, or the specific types of EB, since they're so different. Right? And maybe speak about some of the experiences about some of the patients I know that where you are, and a lot of patients from the Panhandle area may only have access to your center and your clinic, and many of them may have taken a long time to find a physician like you who knows about EB and how to take care of it. Maybe talk about some of these patient experience and journeys.
Right. So, EB is extremely rare, and there will be dermatologists that maybe have never seen EB during the residency training. And on top of that, there's a shortage of pediatric dermatologists in the U.S. So trying to find a dermatologist, then a pediatric dermatologist, and then someone who actually has an interest in EB can be challenging. And you're right, my geographic catchment area in Florida is huge. And so I've therefore accumulated a lot of these patients over the years. There are numerous challenges. One, at birth, confirming the diagnosis, because it can be challenging, and you don't want to automatically assume the diagnosis of EB whenever it's important to rule out other causes, such as congenital infections or others. And the clinical features can sometimes help, but of course, as we know, there are mimickers out there, and dermatology can be challenging. So in the US, the general standard of practice, I think now would be to rule out other causes, but then to start the process for EB testing. And really now that'll involve genetic testing, and especially nowadays when that's a lot more readily available and easier to do, which can be a buccal or cheek swab. It's a lot less invasive than the old days. You and I remember where we had to induce a blister and then do a skin biopsy. And even a simple blood draw, that can cause more trauma. So definitely that is a challenge if you're in a center that has no dermatology, maybe doesn't have genetics, maybe is even unaware of EB as a diagnosis. And then, of course, other challenges come with that. Parents, this might be their first child. They were completely unexpecting this diagnosis or blisters. The presentation can be very dramatic, and so that can be emotionally challenging to patients or to parents. And then, of course, saying to a parent, we have to transfer your child to a different hospital, and certainly in my geographical area, that could be 6, 7, 8 hours away. So that's a challenge. And then, of course, not just as physicians, but there might be other healthcare professionals, such as nurses, who are maybe unaware that these small babies who have very widespread skin disease should be managed in a acute setting, such as NICU or if they're a bit older, PICU.
Yeah. So thank you very much for that. And, it is indeed that, throughout your training, you were very fortunate and you had your training with some of the world experts in EB in Philadelphia as well. Throughout your fellowship and training as well, and you have gained so much experience. Do you agree there's a current lack of training knowledge among even dermatologists and also dermatology practitioners, nurses, and other care providers, and perhaps need to be aware of these conditions and understand the patient journey a little better to help optimize and coordination of their care.
Right, I totally agree. Because it is so rare. You could finish a dermatology residency and have never seen EB. And then when you go into practice, either in an academic setting or in a private practice setting, be presented with an inpatient consult or somebody in the office and be unaware of how EB presents or be unaware of what to do next or having a multidisciplinary team involved. And where I am, there are a lot of EB patients, but just not enough dermatologists, not enough pediatric dermatologists, and maybe just a lack of awareness of what EB care involves. So it is very dependent, I think, on where you did your training. If it's in your end of neck of the woods, then yes, they'll get a lot of exposure. But in certain states, there might not be either any EB or lack of EB patients coming through the office.
Yeah, we also, even on the West Coast, we have patients, fly in or drive miles, many, many hours to come to seek care. Certainly that we recognize and not all patients, even with that, and are able to have the optimal access to care. It is of a challenge. And you have already touched upon, patients' disease manifestation. And the other thing that, I want to point out, you probably share this experience as well. You mentioned a few times about pediatric dermatologists. The reality is that, a baby with the EB, they're born with this condition, and oftentimes, especially the severe types, are recognized and diagnosed early on. But over time, and we all keep these patients. we take care of them, and when they're teenagers, and many of us continue to take care of them when they're adults as well. You establish this relationship and with many of these patients.
Right, I agree, and there'll be a lot of standalone pediatric hospitals that will continue seeing these patients into adulthood. And you're right, you kind of forge a kind of long-lasting relationship. And while the presentations at birth, there are a lot of adult patients who have had EB for years. I've got quite a few who have just been living with EB. Have kind of worked out what works for them with regards to skincare. And I hope with this podcast and also with new treatments coming out, that now that they're starting to seek care with an expert center that can help them.
That's right. And for patients with severe subtypes of EB for young adults and sometimes in teenagers and as well as adults as well, they will start to also, because of the chronic wound and an infection, we're still trying to figure out what are the cause behind this, but as they get older, they have a much increased risk for skin cancer and malignancy, and even with all the treatment and clinical care advancement that we have had, and many of these patients unfortunately still die from metastatic skin cancer as well. So that access to care is absolutely important. Are there any other factors that you think clinicians need to consider when approaching EB care and EB patients?
I think there's a lot. I think skin cancer, you pointed out, certainly adults that are coming in with EB, everybody should be getting a full body skin examination to look for that. And then in the smaller kids, thinking about infection, as you will know, this is a big area, and we could talk for a long time about it. And it can be challenging to determine, is just this normal colonization? Is this true infection? You'll know we try not to culture these kiddos too much, but that can be a challenge. And I think if there are physicians listening that are dermatologists, but maybe haven't seen a lot of EB, it's important for them or the patient to try to reach out and find a local EB expert, which might be far away, but I think it's reasonable to at least touch base with that center. They could have seen the patient at least once and go through the intricacies of what EB and EB care involves. The other important thing to be aware of is that it is a multidisciplinary team. So yes, dermatologists lead that team, are very important, but it is important to work with other specialties and physicians. If they're small babies, that might be the NICU or the PICU, pain management, the dietitian and the GI team, ENT, ophthalmology, social worker, PT, OT, and the list goes on. And I think if you haven't seen EB or you're unaware of that, you might assume it's care involves doing dressings and skincare, et cetera, and then leave it at that when that's just not true. So I think saying to a patient, your local EB center might be far, but it's reasonable to at least touch base with them. And then that center might only have to see them once a year, if even that, if the local dermatologist is able to provide other treatment.
Yeah, I totally agree that really depending on where patients are, and the care model can be modified to provide them the care that they need. And some of the patients, it's the same for us, and that patients who are living a little closer to our medical centers, and we do see them a little more frequent. And for those who are only able to come to our center once a year, twice a year, we establish this alliance with a local physician and work together. And maybe we provide some consultations and comprehensive care recommendations, and then they can help, and local physician can help implement these recommendations and see them a little more frequent and close to home. And especially with their skin condition, traveling, transportation, just get out the house can be very difficult, and for patient as well as their family. So it's a huge commitment, and so we can definitely and establish some sort of network and to support these patients. Now, and the EB is a rare disease, but when there's a rare disease community, and it's also very, and they also provide, and it's usually a very tight knit community, and they provide care and support to each other. Can you also provide to our listeners about resources that you and your patients like to use, and if someone is looking for management guidelines, for instance, and where would be a good place for them to find these resources?
That's a great question. One of the best resources is DEBRA, DEBRA. EB Clinic also is a good resource as well. And any patient that I've diagnosed with EB, I'll speak to their mom or dad and say, go to these websites because they have a wealth of information on it. And that doesn't just include going through the condition in more detail, but DEBRA has a huge resource on fine-tuning things that we mightn't have thought about when they're in the office. That can be simple things such as breastfeeding. What can I do to optimize that so that my baby's getting the nutrition they need? It might be wound dressings. So there are many different companies out there that can help support patients receiving their dressings. And it can be challenging with insurance trying to get that covered. But DEBRA has a nice section of their website that'll give you different options. And then, of course, the social worker can get involved and help with that too. For caregivers that want to learn more, DEBRA also has a conference every 2 years, which is a conference for patients and caregivers. So yes, there's some medical talks and some medical terminology, but a lot of it is moms and dads turning up, trying to work out what can I do to optimize the symptoms that their child is having, or what new treatments are available. So I would recommend they go there. There are several guidelines available. There's a guideline on the consensus reclassification of inherited EB, and that's the current one in the British Journal of Dermatology. That has a very nice, several nice tables in it about the different subtypes and how they can present. A more practical one is one that just got published a few months ago in the Journal of the American Academy of Dermatology on the inpatient management of EB for neonates, but also post-neonates. And there's some very useful clinical information as to what do I do after an IV line has been placed? How do I put a dressing over that? How do I provide either breastfeeding or formula feeding, etc. Those are useful kind of first steps for either patients or providers to go to. And then, of course, there's other information such as patients who will have anemia in EB because they have malnutrition or not absorbing, and what should we as providers do for that? So, of course, hematology may get involved. You might speak to the primary care doctor, but I think we as EB specialists can also be aware that nutrition, anemia, vitamin D, DEXA scans, etc., are important, and their primary care might not be aware of that.
Yeah, I went to a few of the DEBRA meetings, the most recent one in Atlanta, and that was an amazing experience. And in being there so many times, I continue to learn all these practical tips and that I can jot down and bring it back and actually share with my patients as well. The type of shoes, footwear that may suit your child a little better, and the video, how on the DEBRA website, it has also been very helpful. When you put the dressing on the hand, and how do you wrap the fingers so that they don't fuse together? And so it's a very it's a great website and a very, very helpful resource indeed. Thank you very much for mentioning that. And also that, for access, especially dressing. I have had a patient, who posted their own information and mentioned to Deborah that they can't get enough dressing and can't get it covered and received their supplies. So please reach out and share those resources and with your patients. So I think we are getting very close to time. And thank you so much, Dr. Lavery, for your expertise and your input to this wonderful discussion. Now, more than ever, it's incredibly important for dermatology practitioners to be aware of the epidermolysis bullosa and the lifetime burdensome experience these patients endure. Do you have any last-minute takeaways for any of our listeners?
Well, EB is a very rare condition. It's complex, but there is ongoing research. There are now 2 FDA-approved treatments. So if you encounter a patient that you think has EB, and you're in an institution or in the community, please reach out to your local academic center. Go onto the Deborah website and find a center that specializes in EB, and start the process, because management is evolving. Treatment really requires a village of a lot of different people, and please don't let these patients suffer, because there is help available.
Thank you again, Dr. Lavery, for your contribution to this educational discussion. Stay tuned for part 2 of this discussion as we dive deeper into the EB treatment landscape and expert guidance for optimizing disease management. Thank you.
Thank you.
Stay tuned for part 2 coming soon, where Dr. Lavery and Dr. Teng will dive deeper into the latest advancements in treatment for epidermolysis bullosa patients. Thank you.